So firstly, I would like to thank the organized committee for inviting me to give my topic for today, which is the liver transplant in the presence of history of pre-existing extrahepatic malignancy. So my patient is 50 years old male with a history of CRC, stage 2, treated 4 years ago with a resection and chemotherapy with no current evidence of recurrence. He has decompensated liver cirrhosis secondary to Hep C with refractory ascites and MELD score of 17. He came for liver transplant assessment. Given his previous history of CRC, he was asking about, why should I wait to have a liver transplant and for how long? He is concerned about the risk of recurrence of his primary tumor and what about the new cancer risk? What will be the expected outcome after liver transplant? So starting with his first question, why he should wait and for how long? And when we are speaking about the duration, the first number which came to our mind is number 5. But why number 5? It came from the earliest study done by Ben et al., which showed a recurrence risk of 20% in the recipient in the settings of renal transplant. This study comes from the Israel International Transplanted Tumor Registry. It shows a recurrence rate which was 54% if the patient was transplanted within 2 years post the tumor, dropping to 33% if the treatment between 2 and 5 years before transplantation, and reaching 13% with a history of treatment more than 5 years before the transplant. The highest recurrence rate happened in the following malignancies: in the breast cancer, symptomatic renal carcinoma, sarcomas, bladder cancer, non-melanoma skin cancers, and multiple myeloma. This study led to recommendation of postponement of transplantation for 2 to 5 years, depending on the type of the cancer. However, liver transplant differs from the kidney transplant in several ways. First, the need in liver transplant. While kidney transplantation can be maintained on dialysis, thus delaying the transplant, sick patients with decompensated cirrhosis are unlikely to survive for several years, and the risk of recurrence is more for renal transplant recipient compared with liver transplant. Ideally, a similar period of waiting is desirable in elective liver transplant patient with a history of pre-existing malignancy. However, in carefully selected sick patients, one can proceed to liver transplant if the malignancy is proved to be or can be eradicated at the time of liver transplant, and the type and the stage of neoplasm is not associated with poor prognosis. However, the criticism to this study was it was a voluntary registry without a mandatory or defined follow-up period. This makes it prone to selection and follow-up bias, and it tends to overestimate the risk of recurrence. So what about the optimal cancer-free interval? Still, it hasn't been yet established. Some reported that the shorter the cancer-free interval was associated with higher risk of cancer recurrence. Others found no association between the cancer-free interval and the recurrent cancer mortality. Taking into consideration that liver transplant, it is difficult to postpone the timing of transplant because there is no other alternative treatment for liver failure. So the proposed guidelines for interval between the cancer remission and the transplant, it comes mainly from the renal transplant recommendation, and the American Society versus the European best practice guideline showed that in cancers with low risk of malignancy, for example, prostate cancer, thyroid cancer, and renal cancer, it's advisable to wait for 2 years after cancer remission. For cancers with high risk of malignancy, such as colorectal cancer, either from 0, no time waiting, to 5 years, depending on the stage, according to the American Society of Transplant Physicians, versus more than 5 years, according to the European best practice. In cancer breast, it should be from 2 years to 5 years, according to the American, versus more than 3 years, according to the British. For malignant melanoma, waiting again for 2 to 5 years, versus more than 2 years, according to the British best practice. Moving on to what about the risk of primary tumor recurrence? As I mentioned earlier, the historic data showed that it was a high risk. Later on, several population-based studies had shown that the recurrence risk is low. But as we can see, the numbers included were small. That's why we moved on to the systemic review and meta-analysis published by the Canadian group. It included 57 studies. 33 of them examined the solid organ transplant recipient with any type of previous history of malignancy, while 24 studies examined a type-specific malignancy. And it shows the bold proportion of patients with recurrence was 5%. The cancer recurrence rate was 1.6 per 100 persons per year. Subgroup meta-analysis by the organ transplant shows the highest recurrence was for kidney transplant. It was 2.4 per 100 persons per year, compared to liver with only 1%, and the cardiothoracic recipient was 1.3 per 100 persons per year. According to the site-specific cancer recurrence rate, it was in cancers with high risk of recurrence. For example, cancer lung, it was 5.4, followed by the GIT malignancy of 4.7, and the gynecological malignancy 3.9, followed by hematological malignancy 1.3. So the cancer time from cancer diagnosis to transplant, if less than 5 years, it was associated with greater risk of cancer recurrence compared to more than 5 years with risk ratio of 2.8. So in conclusion, the risk of cancer recurrence in recipient with previous history of malignancy is considerably lower than the historical reports used to establish recommendation for listing patients with previous malignancy. What about the outcome of solid organ liver transplant in recipient with a history of pre-existing malignancy? This came from another Canadian study that showed this review article, which included more than 9,000 records, but ended up with inclusion of only 23 studies. The studies were included if they compared the solid organ transplant malignancy with previous history of malignancy versus recipient without history of malignancy, regarding the all-cause mortality or the overall mortality, cancer-specific mortality, and the incidence of post-transplant de novo malignancy. The hazard ratio was for all-cause mortality was 1.5 for patients with history versus those without history of previous malignancy. And it was similar for kidney transplant and non-kidney transplant. What about the cancer-specific mortality? The pooled analysis showed that patients with previous malignancy were at higher risk of cancer-specific mortality compared to those without, the hazard risk ratio of 3.1. And what about the incidence of post-transplant de novo malignancy? The pooled estimate again showed that patients with solid organ transplant with previous history of malignancy were more likely to develop post-transplant de novo malignancy with a hazard risk. So this analysis is associated with identified that there is increased risk of all-cause mortality, cancer-specific mortality, and developing de novo malignancy after transplant compared to those without previous history of malignancy. So what about the living donor liver transplant? This study was the first report to describe the long-term outcome of patients with previous history of malignancy after living donor liver transplant. It was a recent study published last year by the Japanese group. A total of 342 adult patients who underwent liver transplant at a university hospital in Japan between 1999 and 2018 were enrolled in this study. 15 patients with previous malignancy were identified retrospectively. The patients with previous malignancy were considered as a liver transplant candidate when all of these factors were satisfied. Firstly, the patient had received the curative treatment, and the expected 5-year survival rate related to post-transplant malignancy after treatment was 70 to 80% or greater. So of these patients, 15 patients were found to have malignancy before liver transplant. The median age was 60 years, and the median MELD score was 17. The median age at the time of cancer diagnosis was 52 years old, and the total malignancy, it was cancer breast in 6 patients, gastric carcinoma in 2 patients, colon cancer and thyroid cancer, laryngeal cancer in equal numbers of patients. The basic immunosuppressant used was tacrolimus and steroids after living donor liver transplant. The median interval from the treatment of cancer to living donor liver transplant was 57 months. 2 patients with gastric mucosal cancer underwent endoscopic mucosal resection and received living donor liver transplant at more than 3 years after the endoscopic mucosal resection. The deteriorated liver function of patient with advanced cancer colon didn't allow to delay the transplant, and this patient underwent living donor 19 months after the curative treatment. In patients with breast cancer, the median interval was 80 months before the transplant, and in patients with acute myeloid leukemia, over 20 years after achieving complete response. No patients with previous history of malignancy experienced recurrence after primary treatment of the cancer before living donor liver transplant. One of the 15 patients during the follow-up period died from sepsis, which is an event not related to the previous history of malignancy. A total of 98 from the 327, none without previous history of malignancy died during the follow-up period. The survival, it was 1 year survival, it was 100% for patients with previous malignancy history versus 86% in patients without. And the 3-year survival was 92 versus 80, and the 5-year survival was 92 versus 76. No patient died of de novo malignancy or recurrence in patients with previous history of malignancy, while 8 patients died of de novo malignancy in the non-previous history of malignancy. And there was no significant difference in the cancer-specific mortality rate between the 2 groups. So concluding in this study, the recurrence rate of previous history in patients with previous history of malignancy after living donor liver transplant is low, and it is not associated with an increased risk of overall mortality or cancer-specific mortality. The results suggest that patients with previous malignancy can be considered as candidates for living donor liver transplant if appropriately selected. So confident enough that now I can return to my patients with the following take-home messages. Systematic review and meta-analysis has demonstrated the risk of cancer recurrence after solid organ liver transplant in patients with previous history of malignancy is lower than reported in the historic literature. For candidates of non-renal transplant, it is recommended that transplantation can be undertaken provided that the neoplasm has been eradicated and the oncological expected survival is superior to the survival expected after transplantation. Liver transplant in patients with previous history of malignancy should be a multidisciplinary team approach with discussion about the indications, the expected outcome, and the survival among hepatologists, transplant surgeon, and oncologists. With careful selection of transplant recipients with previous history of malignancy, tailored screening, and management strategy, good outcome can be obtained. Thank you.